Hello and welcome everybody uh, to my presentation here on systemic exertion intolerance disease, also known as chronic fatigue syndrome, a route to resolution. And then I am going to be giving for the next 75 minutes for the New Hampshire Association of Naturopathic Doctors CE series. You should be able to get 1.5 units on this. And this I think is a good topic for naturopathic doctors. To even just integrative medicine, functional medicine providers in general, to know more about how to work these conditions up and how to treat them and what I've seen work clinically, because conventional medicine doesn't really have much to offer. So we tend to get a lot of people who, whether they meet all the criteria for chronic fatigue syndrome, they still present with extreme fatigue. And I think there's a lot of options and things that we could benefit to help. So I want to thank NHAN for asking me to speak to you today about this topic. Here are my disclosures. And so for me, I'd like to kind of have an overview of what we're going to be talking about with chronic fatigue syndrome, which is also called myalgic encephalomyelitis, which just sounds horrible. It sounds a lot more severe than chronic fatigue syndrome. The Mayo Clinic actually refers to it appropriately as chronic multifactorial fatigue. And in 2015, the Institute of Medicine actually wanted to have the diagnostic criteria and everything redefined and have it changed from systemic exertion intolerance disease, or SEID. Now, I'll go back and forth between CFS, chronic fatigue, SEID. They're all the same thing. Most people don't know what SEID is, at least in North America, just like most people in North America don't know what myalgic encephalomyelitis is, because ME is what the term they use for this condition in the UK. So let's kind of actually take a look at diagnostic criteria, because for those of you who have heard me speak before, or read my writings, or heard me speak last year at Enhance Conference, which was great, by the way, that I'm really into knowing diagnostic criteria, knowing what meets the definition of someone having a particular disease. Not because I need a label or I like labels, is that if you understand what is going on as far as what leads someone to this, what are the signs and symptoms, you can have an accurate diagnosis. If you have an accurate diagnosis, your treatment strategies and interventions will work better than what a lot of clinicians tend to do, conventional and naturopathic and functional medicines, that they just kind of throw everything at someone when they have very complex conditions like CFS. So I would just like to review these, and people know I can get pedantic over some things, but I think it's important for just about any disease, if not all of them, to understand all the criteria. So first, let's look at the Institute of Medicine. And I'm not going to read these verbatim and put you all to sleep, but the diagnosis requires the patient have the following 3 symptoms, right? Some kind of substantial reduction or impairment in the ability to engage in pre-illness levels of occupation, et cetera, et cetera, et cetera. So essentially, they lived a certain life at a certain level one day, and then just like literally overnight. And you'll hear this from patients as I tell you their story. You're doing your history of present illness. They'll tell you all of these things, right? You also must have post-exertional malaise, and you must be unrefreshed sleep. So these are people that sometimes, many times, have hypersomnia, right? They sleep too much, even if it's good sleep. I mean, I've had patients report to me that they sleep 12, 14 hours a day, and they're still exhausted. And then in addition to those 3, you must have another manifestation, either cognitive impairment or an orthostatic intolerance. And then here you can see the frequency and severity of symptoms should be assessed and diagnosed. And it has to be at least half the time, and it has to be moderate and severe. And that's where kind of fatigue scales can come in. And I've had lots of patients just say, I was at this level in my life before I got sick, and then now I'm down here. And then I'll say, well, what's your energy averaging? And they'll say, and the scale I always give usually is 0 to 10. 0 means you can't get out of bed. 10, you're going to go run the Boston Marathon. And people will usually be like, oh, I probably average a 7. Well, that is not technically chronic fatigue syndrome, because it's not at least moderate to severe most of the time. If you're averaging 7 out of 10, that's pretty good, energy levels. And then this is the key in the red box. That's why I put it, or in the box with red, is that symptoms have to be present for at least 6 months, and they have to have moderate substantial, or severe intensity at least half of that time. And I usually kind of talk to people, well, when do you feel that if you have an energy that averages 3 out of 10, when do you get to a 10, or do you get to a 10, or do you get to a 9, and how often does that happen? And you can kind of get a good idea of where they fall and how severe their symptoms are. Now, here's the CDC criteria. Another reason why this disease is sometimes difficult to diagnose, in that the fatigue of chronic fatigue syndrome, right? It's accompanied by characteristic illness, has at least 6 months, just like the Institute of Medicine. And there, for me, this kind of makes a lot of sense, right? Increased malaise, extreme exhaustion and sickness following physical activity or mental exertion. You'll see this. This is part of the criteria, right? Is that these are individuals that even the most mild to moderate intensive physical activity will make them completely wiped out. I have patients, sometimes it's for hours, some of them are for days, some of them it takes them a week. Problems with sleep, difficulties with memory and concentration, persistent muscle pain, arthralgias without erythema or edema or swelling, headaches, cervical axillary tender lymph nodes, and pharyngitis. That's their criteria. And I kind of usually end up with an amalgam of when people see me. And by the time they typically see me, they either have the diagnosis already or the other half don't have the diagnosis, but it's pretty clear cut and they may have had it for many, many years. So let's look at some statistics, right? I mean, how much are people, how many people really are affected, at least in the United States. So it kind of depends where you look. Like with most epidemiological data, it kind of depends where you look. So one prospective cohort study of 4,000 patients in a health maintenance organization, they estimated about, 75 to 267 cases per 100,000, which is quite a large range. But if you didn't have the really more strict Institute of Medicine definition, these cases they're going up between 5 to 20 or 30 fold or even more per 100,000. And remember, these are also people who are actually getting diagnosed. They're presenting to them. These are not people that are walking around undiagnosed. So really look at prevalence rates depending on the definition between 3.3 to 2.5%, which is very small. These numbers would be much more skewed, say, in my practice or someone who sees this a lot, right? I mean, I'm seeing this far more often, just because I've dealt with a lot and I've spoken about it at conferences and for healthcare practitioners as well as the general public. And then, they kind of flock to you once they realize that you know what you're doing. Prevalence is generally about 10%. Females, not surprisingly, and we'll talk about why that's not surprising, they comprise they comprise at least 75% of SEID CFS, not compromise. But there's two reasons for that, and we'll go that in another slide. One of the reasons also because generally speaking, women tend to go to the doctor more than men, right? Men, you cut off their arm, they're just like put some duct tape on there and suture it up. I don't need to really go in anywhere, put a tourniquet on there. Women are more willing to go into the physician's office first and get worked up. And it tends to primarily affect young and middle-aged adults. So what are the signs and symptoms that you got the criteria, but what are you really going to see in your office? And this is what I see a lot, right? It's relatively sudden onset of fatigue, and in well over 250 cases of these, I would say 98% of them, people will say it's bizarre. I was fine, and then I was not fine. And I would say maybe 3/4 after you prod them, especially if it's been a long time, 10, 20 years, they don't remember what happened. But I just had a patient 2 weeks ago who she's 24 years old. And, I said, well, when did you first start noticing symptoms? She's like, oh, like a year and a half ago. And she didn't put the pieces together like most people don't. And I'll say, okay, you remember this it was July 4th. She happened to remember that because it was July 4th. She's like, I always remember July 4th feeling like this since of last year. I said, well, what happened a week or two before that? Did you remember getting sick? And she thought for a while and she's like, actually, I had a really bad cold about a week or two prior to that. So again, you can often see it's associated with, typical infection, upper respiratory infection, true mono, and we'll go into that later as far as diagnostic workup. And it's overwhelming fatigue with additional symptoms, altered sleep and cognition. Uh, and altered sleep doesn't mean that it's a sleep dysfunction, right? As I previously mentioned, it doesn't necessarily mean the person can't sleep. A lot of times they can sleep; they're sleeping too much, and they just are exhausted the next day. Excessive physical activity characteristically exacerbates the symptoms, and people that have severe CFS, it's not even excessive. I have a patient now, for the last 25 years of his life, he can't walk more than 2 blocks around his neighborhood before he is physically exhausted, his muscle fatigue. And he's seen, every specialist under the sun, and they're like, nothing's wrong with you. And he's like, there is something wrong with me. I shouldn't, be like this. Some people, right? I'm a higher energy person. Some people are just low key. So you have to kind of differentiate that. And for this gentleman, since it's been going on most of his life, I said, were you this way as a kid? Were you just one of those kids that, you know, tired easier, didn't seem to have as much energy as the other kids? Because he's a mellow guy in general when I talked to him. And he was like, no, I think I was average. I played soccer. So you could see that it's not like he was just born fatigued. But of course, it affects patients. They're affected patients say they're struck down by something. They're usually high functioning, completely normal, and but it should be noted that there may be a history of some kind of psychiatric disorders, but it's our job as a holistic care practitioner to tease all that out. Did the chicken come before the egg, right? So I usually ask people, they're like, well, I'm really anxious now. I'm really this now. I'm really that. And I said, well, have you always been like this? How were you earlier in your life? And some people will say, yeah, I'm, always been kind of a nervous Nelly. Some people say, no, not until I got this. And then as they progress through their disease and more people or don't believe them, they think it's just, they're malingering and it's all in their head. The more that these individuals then, of course, feel distraught, and then they're more anxious, more depressed, because they can't even do their activities of daily living and nobody believes them. They're out of a job. You can see where this is going if you've seen patients like this in particular. So why is it so difficult to diagnose, right? You know, and it's a syndrome. Remember, a syndrome in medicine, right, is nothing but a constellation or a cluster of a bunch of symptoms that nobody really knows what's going on. So you get dumped into a syndrome, right? Irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia, even that's a syndrome. Um, so once the inciting illness, if any, and I have plenty of patients that say, no, I never got sick, and that's our job to dig. It's resolved. Physical exam is totally normal. You know, although the patients feel febrile, they feel feverish, rarely do they ever actually have elevated temperatures, whether that's oral, temporal. So what I do with patients is that unless they come in feeling febrile, I will ask them to keep a record of their body temperature. So when they come and they're like, I feel febrile, take your temperature, write it down. And I usually have them do a few of those and send them to me. And sometimes they're elevated, sometimes not. But you also got to take into consideration that a lot of these people, if you just test them in the office and maybe they even have underactive thyroid condition or whatever, they kind of have a lower body temperature to begin with. They're sitting at 98 Fahrenheit, orally, or 97.9, 97.6. So if they're going to get to 99, that is a fever to them. I'm a person that I run around 98. I'm a very warm-blooded person. So when I reach 99, 99.5, I am very feverish. I don't need to get it to 102 to be like, man, I am sweating bullets. Um, they typically describe that they have joint pain, but yet when you go in to do your physical exam, they've got no redness, there's no effusion, there's no limitation in active or passive range of motion. Physical exam essentially is normal. They report that their muscles are easily fatigued, but yet they might be +5 on their muscle testing, and we're not talking about applied kinesiology. We're actually talking about, when they go against resistance. Biopsies are normal, electromyograms are normal. I have lots of patients go to the neurologist, or even I send them to the neurologist and they might get an electromyogram and they're like, your nerve function is totally intact. So again, now they're starting to think, well, this is all in my head. And it's not. And we actually have subjective and objective evidence for this. I mean, it's more than just subjective that they're telling you, but we'll talk about objective evidence. And then they will report that there's mild cervical and or axillary lymphadenitis, painful lymph nodes, lymphedema, but no true lymphadenopathy. It's not really present. So there's no swollen, but they might say it's inflamed. And Again, I have had plenty of patients come in and they'll report that, and I will feel their cervical lymph nodes, and they are swollen. They might be a little shoddy, the shoddy lymph nodes when they're like little BB pellets. But is that because maybe they had a lot of infections in the past, or is it they really truly have some kind of waxing and waning infection? But what's interesting to note is that even though everything is normal, but when these lymph nodes are biopsied, they do show under the microscope that there's a kind of a reactive hyperplasia. There is a growing of these cells. So they're most commonly involved, and I would say the axillary lymph nodes may be affected, but in my patient base, most often they end up saying that they feel like their lymph nodes are swollen. Sometimes they could see them in the mirror, and sometimes I'll be able to palpate them. At least when I had in-person practice, and now my practice is 100% telehealth and has been for the last 3 years, 2.5 years. So before COVID, I was 100% telehealth. Sold our practice a few years ago. But even when we had an active practice, I had about 30% telehealth from patients literally all over the United States and all over the world. So I can't that's the drawback, right? You can't do physical exam with telehealth. Other diagnostic difficulty with routine labs, right? Your CBC, your CMP, thyroid panel, they're only causation, these aren't my values, this is actually what data shows, that they really only elucidate causation in about 5% of cases. There's no specific tests available, and this is conventional world. We're going to go into my world and how I work people up and how I get diagnoses and to get people better. Many patients, they're partially completely disabled by its manifestation, right? They're on disability, no one's believing them. They've spent their life savings trying to get better, and they're no better. And now they got all the stress of finances mounting up. The illness has a pattern of remission and relapse, which is beneficial when it comes again toward history and taking, and we'll talk about that. And outwardly, they look normal, they feel normal, but internally they feel horrible. And I would say this is true of just about all of them. Like, just talking to them, they don't look sickly. And then, of course, they're accused of malingers, worsening their physical and mental symptoms. So the reason we talked earlier about women being 75% of the patients is because there's actually quite a bit of overlap with even the symptomology of fibromyalgia, which tends to be more common in females. So if you looked at 70% of patients with fibromyalgia, they technically also meet the definition of chronic fatigue syndrome. So look at these similarities, right? And this is straight out of Up to Date, is that if you look at the clinical similarities, also known as chronic fatigue, 80-90% are women, and they're usually 20 to 55, right? A large age range. My chronic fatigue patients, they tend to see me probably on average mostly in their 40s, but they could have had symptoms long prior to that. They just never were accurately worked up. And plus, it took a long time for them to really get quite sick. Myalgia and fatigue are more, they're in 90%. Common symptoms: neurocognitive mood disturbances, headaches, sleep disturbances. There's no known cause. Testing is normal. Physical exam is normal. Normal laboratory tests. Chronic symptoms, no high effective therapy. So you can see these are basically one and the same. And for me, I would say that I do have a number of patients with CFS. They meet all of these overlapping criteria or symptomology, but they don't really have muscle pain. They never really describe it as muscle pain like a fibromyalgia person would. They usually describe it as like an ache or a fatigue. They're like, how I feel fatigued, if I go and I walk for 15 minutes lightly around my block, I'm fine. If I walk 20 minutes, I am completely wiped out. And that's what we hear people out, and they're like, it's not so much about muscle pain, it's more of fatigue. And that's where I would see, even though this shows that a lot of overlap with the pain, I don't see it so much, but everything else meets it. And, I will usually just kind of treat them. But I treat CFS and fibromyalgia slightly differently, but for the most part, I'm actually the same, and I get the same results for things going to remission. Excuse me. So these are proposed etiologies. And so again, they said, well, there's no known cause. Well, our job is to find a cause. And once you find a cause, then you know what to give them. So if anybody's ever seen these patients with chronic fatigue, and you know the the doctor they saw before, Dr. Google, their neighbor, their friend, their family, the health food store clerk, everybody's giving them all these supplements and they don't feel any better, right? And these are all well-intentioned people, and most of the time they come to me in these bags of supplements. And they've been taking them, and they're not really, and they're good quality supplements, and they're taking reasonable doses, but it's not working. And there's a reason why it's not working, is because nobody looked to see what the actual etiology or etiologies were. So let's look at viruses and bacteria. And again, this is the data. If you feel like pulling the research papers, even from the CDC's, that Epstein-Barr virus, humans herpes virus simplex 6, cytomegalovirus, enterovirus, Coxsackie B, Ross River, Borneo disease. I mean, a lot of these aren't even in the United States. Xenotropic marine leukemia virus related virus. That's a mouthful, also known as XMRV, murine leukemia virus, mycoplasma, Coxiella. And then this ellipses here, right? Because it goes on and on and on. And when I have this discussion with patients, or even their doctors, and they want to be tested for everything under the sun, um, you can't test for every virus. There's millions of viruses, hundreds of thousands that affect humans. So you can test the common ones based on symptomology, a history of present illness, travel, where do they live, those kinds of things. And you can also look at the CBC to see if there's changes in the lymphocyte count, or if they're low normal, or even the leukocyte count. And you'll see that because as these people are so sick for so long, the circulating pool of white blood cells can become depleted, and then they're sick all the time. There's no more waxing and waning of their illness, and you will see changes in CBC, just maybe not overt. They might be low normal, so you can kind of know something's going on. Also look at immune dysfunction compared to healthy controls, right? We've seen in subjects, right? So this is objective data, so it's not in their head, that when you compare someone who has chronic fatigue syndrome to a healthy control, they have decreased immune complexes, decreased natural killer cell function, altered IgG levels, and altered CD4 or CD8 ratios. Interferon and cytokine activity and IL-2 all go up, right? So the immune system is definitely activated. And then there's endocrine metabolic dysfunction, which, no surprise, right? Physical or emotional stress, it's commonly reported as pre-onset condition, alters the activity of the hypothalamic pituitary axis. And I would say that we learn all about this in school, right? The HPA axis, and we beat that drum all day long, but there's constant crosstalk in the endocrine system. So I would even go further to say it's the hypothalamic pituitary thyroid adrenal axis. And if you're a female, the hypothalamic pituitary thyroid adrenal ovarian axis. And yes, men with testes because testosterone, but I wouldn't put it as much in as when you see women with all these endocrine issues, but yet their adrenals fine, their thyroid's fine, but they have these gynecological issues, like menorrhagia, dysmenorrhea, it's severe, that's all in crosstalk. Uh, Other etiologies, right, is this, but again, it's chicken or the egg. Is it, do they have neurally mediated hypotension, also known as POTS, right? This postural orthostatic tachycardia, where they're sitting down, laying up, and they get up, and then they're just, their heart rate goes through the roof. I would say that this isn't a cause. I'm just giving you what the papers show. I would say that this is a symptom. Because someone has POTS now that they have CFS, no, I say it's the other way around. Neuropsychiatric factors. So 2 out of every 3 people who have chronic fatigue syndrome also have some kind of neuropsychiatric disorder, depressive disorder, anxiety disorder. And I would just ask your patient, be very candid and be like, okay, well, what was your mood like 5 years before you felt like this, or, do you have this, do you have that? And it doesn't mean you're always going to get 100% honest answer. I have people all the time, patients all the time, I'm sure you do too, that they're not purposely maliciously lying to deceive you. We see ourselves differently than everybody else sees us. So I have a patient, for example, who got floxed years ago, right? She took ciprofloxacin and has had it been a downward spiral quite since. And she reports to me that she never had any anxiety before this, but I've had the ability to talk to her husband, in a different, avenue, because he didn't feel comfortable saying it in front of her. But I said, well, how was she like? Was she an anxious person before us? He said, yes, but it's certainly gotten a lot worse. And So you try to kind of tease that out and get to know family and other people, and hopefully you can put a piece of the puzzle together and really know if this person had some kind of neuropsychiatric disorder before. But what we can say for certain, at least I can say for certain, is that it's whatever they had before, it's certainly going to be a lot worse, right? That their anxiety is going to be way worse, their depression is going to be way worse, and then it's a negative feed forward cycle, right? Because if your mood is all messed up, then you're not going to get much better. So you got to treat that at the same time. And then, of course, we know that genetics is always at play, right? DNA sequences, changes in 3 genes associated with the brain function, stress reactions, emotional response. They've actually looked at people versus healthy controls, and they're seeing differences in how someone who has CFS responds to their own chemical messengers, their own hormones, instead of healthy control, which makes sense, right? Why would someone who got infectious mono in college recover, and why would subject B become a train wreck? Genetics. Which brings me to genetics always at play. And I say always is because whenever you look at something that's a chronic disease, you know, autoimmune disease, pandas, the list, FAPA, it goes on, is that someone has to have a genetic propensity, right? So there's this, kind of idiom, I guess, if you will, in medicine where the genetics loads the gun and environment pulls the trigger. So someone has to have some kind of genetic propensity. They get an insult, whether it's a physical stressor, emotional stressor, an infectious stressor, and now they go down the path. And so we looked at is that polymorphisms in genes regulating the HPA axis associated with unexplained chronic fatigue. So these is a paper where they looked at genetic differences in people who are healthy and people who had chronic fatigue. And what's interesting for those of you who love to run a lot of these genetic tests and look at the SNPs and get all crazy, which I don't, and it just does. I don't need to because most of it you can infer. But I do get a lot of people that come to me with their 23andMe results, or they put into Sterling's, app, and they want me to interpret them. And I find them to be somewhat useful because if you know someone's genetic SNPs, right, you can make predictions. But just talking to someone and knowing how they react to things, that's going to tell you what's going on anyway. And I use constitutional homeopathy in my practice. So it's going to optimize their genetic potential anyway. So it doesn't matter what SNPs they have. But for those of you that like it, and for patients themselves who want to know what's wrong with me, we know these are all these genes that have been shown to be aberrant in people who have CFS compared to healthy controls. And so it even says these data support the hypothesis that medically unexplained chronic fatigue, it's heterogeneous, and it's evidence that there's some kind of genetic mechanism. No brainer, really. Here's just another paper that I like just because of the conclusion about, and this is a good paper out of pharmacogenomics, and they looked at 28 out of several million possible single nucleotide polymorphisms will actually predict. So just 28, right? With 76% accuracy of who might get CFS or not. And here again, these are the ones. And again, and if you look at these and know what these do, they're not surprising, right? Catechol-methyltransferase breaking down catecholamines, the ability to be able to synthesize tryptophan, glucocorticoid receptor. None of these are terribly surprising. They're kind of obvious. And this is one reason why I don't do genetic testing anymore, is because it's you can talk to someone and you can infer most of what's going on, and it's all quite predictable without giving you more to worry about, essentially. Other etiology is just some kind of mitochondrial dysfunction. Again, and we're not talking about babies that are genetically born with inborn errors of mitochondrial problems, and if they're severe enough, those children don't usually live very long. What they think is that something happened along the pathway of life during this infection that caused some kind of mitochondrial dysfunction. And there's a major immediate cause and lack of essential substrates and partial blocking of translocator proteins. In other words, the mitochondria is now dysfunctional and it can no longer make ATP in a normal way, and therefore the person is tired. And this is what you'll see a lot, or at least I see a lot, when people will, whether they self-prescribe and or other people have recommended things, they come in with, all these mitochondrial precursors, L-carnitine and lipoic acid and NAC and NAD, and they're getting IVs up the wazoo, and they're really not any better, And there's a reason for that, and we'll talk about why. You can give mitochondrial precursors until the cows come home, as they say, and the person's not going to get that much better. They're just going to spend a whole lot of money. So metabolic features of chronic fatigue syndrome. Here's another one on metabolomics, right? So these are metabolomics. Everything's the whole about omics, right? Proteomics, metabolomics, epigenetics, all these omics. Metabolomics looks at metabolites, whether from normal physiological reactions of the body. And this was a great paper that actually showed from the proceedings of the National Academy of Sciences in 2016 that patients with CFS, they showed abnormalities in 20 metabolic pathways. 80% of their diagnostic metabolites were decreased, consistent with a hypometabolic syndrome. Basically, a lot of words for someone who's got chronic fatigue. They're just hypofunctioning. They can't produce ATP. Their normal biochemical pathways are just slowed down. They're like working in quicksand. And this is what's interesting, right? Is that pathway abnormalities included sphingolipid, phospholipid, purines, cholesterol, microbiome, the pyrroline 5-carboxylase, B2, branched chain amino acids. I mean, the list goes on and on. So the point of this paper and the point of the genetics papers is that now there's proof, right? And I will sometimes, when I get patients that come in and they're just really distraught and how nobody believes them, I don't go into the super heady science unless, like the one gentleman I have who can only walk 2 blocks. He is an engineer of some kind, of course, and he's super heady. He wanted all these papers and he wanted to understand what's going on in the last 35 years. But the point I bring to people is that, you know what? This isn't in your head. There's good proof. I believe you. There's proof that there's abnormalities going on in your biochemistry, and we're going to fix that. And that just gives them, that's part of the therapeutic relationship right there, right? Is that you're giving them hope. And it's not false hope, it's true. And I'll show you how I have helped people and what I do actually exactly with these cases. So my approach to the differential diagnosis, right, is that first of all, I mean, there's not much in medicine that has a longer problem list than fatigue, right? It's very nebulous, it's very vague, and you got to rule all those out. Organic and inorganic causes, right? Are they sleeping well? Do they sleep through the night? How much are they sleeping? What time do they go to bed? What's their thyroid function? What's their iron status? What's their B12 status? What's their diet like? You got to rule all those out because some people, you know, they, pardon my French, they eat crap every day, right? And I'm like, dude, it's garbage in, garbage out. You can't sit and drink Red Bulls and energy drinks and McDonald's twice a day and think you're going to feel great. Maybe some people do, most people don't. So we got to work on all those, but that's all part of that first visit when it's just data gathering, and then me asking them pinpoint questions, and then running a lot of blood tests, which we'll talk about here in a moment. Looking at the comorbidities, do they have fibromyalgia? Do they have sleep dysfunction? Do they have sleep apnea? I've had a lot of people where I've gotten them and they don't have the classic sleep apneic person. They don't have the big neck. They're not smokers. They don't have any, rhinosinusitis, no allergies. Their partner whom they sleep with doesn't have a report that they are apneic. So they don't have moderate to severe apnea. I'll send them for a sleep study and they will come back and they'll have apnea. And, then we have to address that. Look at some kind of, dysglycemia, hypoglycemia, postprandial syndrome, which is different than true reactive hypoglycemia. Reactive hypoglycemia, right, is the person eats the food and then they're, within a certain time frame, their blood sugar just tanks. Postprandial syndrome is more what we experience a lot in medical school, right? You're tired all the time and then you eat lunch and then you're just a crash. So that's more postprandial syndrome where you got to look at insulin sensitization and adrenal function, et cetera. Routine labs, and these are my routine labs, right? And I am known in most communities that I have patients that I'm a vampire, and it's not because I like people getting poked. It's because I tend to get a lot of complicated patients who just have never had the thorough workup. So I need to run a lot of tests so I understand what's going on, particularly with something like this. So I'm looking at, the CMP, CBC, a lot of stuff that we all run anyway. I kind of throw in the creatinine kinase because that's important to see. Is there maybe some kind of underlying muscle dysfunction before I send them to the physiatrist or the neurologist for a muscle biopsy or something more intense and painful? why don't I run a blood test and see if there's some enzyme issues there. Of course, running D, hemoglobin, A1C, um, ruling out autoimmune disease. I can't tell you how many patients I've had that just never even had an ANA run. And it turns out that their severe fatigue is caused by their chronic pain because they have ankylosing spondylitis, which is not ANA positive, or their rheumatoid arthritis or whatever. And then looking at thyroid antibodies, right? Uh, you guys do this all day. We all do this all day. I won't harp on those. The reason I like a lot of inflammatory markers is because the body has many, many, many ways of making inflammation. So just because I see all the time CRP may normal, but then HSCRP is like high normal. But then maybe the SED rate is, is 20, 25. So I like to kind of look at a lot of them. Plus, I use blood tests as a motivator to patients, right? A lot of patients, they're subjective people. They like data, even if they're not an engineer. And so if I can show them these numbers, that makes them more adherent to the recommendations I'm going to make, because then they know when I tell them, when I see you in 3 months or whatever, I'm going to rerun some of these tests that were abnormal and see if they've come down. So they're going to take those high doses of turmeric or these high doses of B12 because they're like, oh, Dr. Bourne's going to run these things on me. I got to step it up because he's going to, blah, blah, blah. So this is where I start getting into the, say, higher level tests in these patients. So I like methylmalonic acid, right? Because and I would say add in B12 to that, is that B12, we all know, is not a very sensitive indicator of B12 status. B12 gets stored in the liver. It's slowly released over time. So even a vegan or vegetarian, it would take a long time for them to become deficient, but you could pick up insufficiencies. Methylmalonic acid is a more sensitive test, but you can combine the two and get higher specificity and higher sensitivity, and you're more likely to pick up B12. Some people say, well, why aren't you just giving B12 anyway? It's water soluble unless they have kidney disease. And the answer is no, because if they're deficient, I might give them injections and replete them quicker, but I'm not going to give people something they don't need. So looking at RBC, magnesium, and serum. And the reason I do both of these, right, is that intracellular, anything is difficult to test. The gold standard for magnesium status is that you do a magnesium load, usually from an IV push, and you measure magnesium through the urine before and after. That's not practical in clinical practice. So I like to do both. And the reason is that RBC magnesium, which a lot of doctors like to run, it's very subjective to the phlebotomist's ability, or you, to pull the blood correctly. In other words, it's really easy to skew the results if you don't use the right tube, the right amount of blood. If you shake it too much, shake it too little, it's sensitive. Serum magnesium is much more stable in the test tubes. And this data, this isn't me making it up, this comes straight out of Mayo Clinic. So I like to run both. Ionized calcium, because the kidneys and the lungs, particularly kidneys, they're going to tightly regulate calcium. So I'm going to try to make it more sensitive to pick up a calcium problem. Make sure that that's not what their muscle fatigue is about, right? You need calcium and magnesium for contraction and relaxation of muscles. Zinc, iron panel, ferritin, these are all crucial. I'll give you another example. So I had a patient who was coming to me for chronic fatigue. She's 35, and she went and saw a functional medicine doctor, and they ran just about every test, but there were some holes in it, right? They never ran pregnenolone. They ran ferritin and a CBC, but no serum iron, no percent saturation, no transferrin. So you're not getting the full picture of someone's iron status without these. DHEA, sulfate, testosterone, fractionated estrogens. And again, I'm not going to run every single one of these tests on every single patient. These I will, most of these I will, but it depends on their case, of when I'm going to run on not, because common cause of fatigue and say depression in men is low testosterone. Gets missed all the time. These I will almost always run. And what I ask the patient is, when they've given me their history, I'll say, and they're done, and I go to my review of systems, I'm like, do you ever feel like you have a fever, even if it's not by a thermometer? Most often they'll say yes. Do you feel like you get a sore throat that comes and goes? Yes. Do you feel like you have, lymph nodes in your neck that feel like they come and go as far as being swollen? Yes. So now I'm thinking they have a virus that's a common cause of their chronic fatigue, and I just need to know which ones they really are. Because remember, anything in the herpes family that humans are exposed to, we never fully clear any herpes virus. So it doesn't matter if it's, herpes zoster or Epstein-Barr or cytomegalo. They always live in our central nervous system. Just they're opportunistic infections. They're waiting to get reactivated. So you'll see this a lot with people too, that they may not remember an infection years and years later, though. They're under a lot of stress, they're working a lot, they got a bunch of kids, and just the stress, chronic cortisol, right, suppressing their immune system. These critters living there are just like, this is going to be sweet. Now my immune system isn't as hyper vigilant, I'm going to reactivate. So it's important to run all of these, and they have to be quantitative titers, not qualitative. Who cares if they're plus or minus? 90% of North Americans have been exposed to Epstein-Barr. That doesn't help you. You need titers to show how much virus is there, based upon their where they live, where they travel. Have they ever been screened for tick-borne illnesses? Right, Borrelia, Babesia, Anaplasma, Rickettsia. The list goes on and on. Mycoplasma pneumoniae, really common. You'll be elevated in people. You give them a dose of azithromycin, and all of a sudden they feel like $1,000,000. Mycotoxins, and again, when I start going down this road, is if I run all these tests and everything's normal. And then I'm like, well, let's maybe talk about mycotoxins. For example, the patient that I had who could only walk for 2 weeks, the engineer, his everything was totally unremarkable. And he's seen all the specialists. And as we started talking, I said, "Do you live in a moldy place?" And he said, "No." And then he thought about it. And he said, "Actually, when I was a teenager, my parents moved to Paris, and we lived in an extremely moldy apartment. And I lived there for over 10 years." And he's like, "And now when I think about it, my symptoms really kind of started in my early 20s. Tested him for mycotoxins, everything else was normal. He had 3 or 4 of these that were like on the highest end of the range, almost to where the lab couldn't even measure them anymore." And I don't use urine tests because mycotoxins, um, most of them they're bound to albumin. Unless someone has kidney disease, it doesn't pass into the urine. I prefer a blood test. And because this is CE, you're typically not allowed to say, things, but the lab, people always want to know, and there's no Q&A here. The lab I use, and I have no affiliation with them, but it is FDA cleared, and all these wonderful things. It's my Myco lab, and it's actually run by Dr. Andrew Campbell, who is one of the world's leading experts in mycotoxins. And I've used his test quite a bit, and patients just pay them directly. They get the receipt, give it to insurance. So urine and blood heavy metal assessments, that's a whole nother, long talk about, pre and post provocation. Do you do it? I personally don't do provoked heavy metals assessment because, one, there is no data. There's nothing to compare it to, right? And there's no NHANES data. There's nobody showing what the median exposure is to someone who had a provoked test. Plus, different heavy metals have affinities for different um, different chelators have affinities for different heavy metals. So you'll see this a lot, is that someone might get an EDTA and DMPS push and then measure their urine to try to capture more of those. I personally don't. I just have them do 24-hour urinary heavy metal assessment from doctor's data. I have no affiliation with them, and it's a cheap test, but no breast KCA foods, no thiol containing anything, NAC, alpha pulvic acid, because those are heavy metal mobilizers, um, a day before the test and the day that they collect the urine. Then when you get those results in, you go to the NHANES data. They have a heavy metals report that you can then, and they update it once a year, and now you can actually risk stratify. So even if from the lab says their arsenic is in the 5th percentile, don't worry about what that lab says. Compare it to NHANES, and all of a sudden you might see that they're in like the 95th percentile for heavy metal burden. So don't be misled by what the lab says. But I do like doctors' data just because their equipment tends to be reproducible and more sensitive. But again, no relation. So one question I get from people is, well, and that's a lot of blood tests. How do you get insurance to cover it? So if you remember, when you're running tests on people, insurance, when you're going for, say, the diagnosis of someone, they don't like it if you rack up all these diagnosis codes, because they think you're just trying to upcode the person and make them feel make them act like they're sicker than they really are, even if they are sick. So you never really want to use more than 4 or 5 diagnosis codes. Blood tests, totally different world, because you're working on a differential diagnosis and they associate those tests with certain codes. So load up those coding sheets, and I will load up those codes all day long. And I've had thousands of patients over the years come back to me and be like, man, how did you code that? I only got a $30 bill for my insurance. But I do usually ask them before I get vampire on them, what's your lab coverage like? Because I have some people are like, I got to reach $1,000 deductible before they'll cover anything. So I'm not going to get super crazy on the test. I'll kind of cherry pick more. This is kind of like the premium of what I would run on people. And here's all the codes I use, right? A lot of screening codes, and then also symptomology codes, and how to get things run. So here's how you actually need to interpret Epstein-Barr virus, is that to be reactivated, you have to actually have the viral capsule antigen, the early antigen, and the viral, this is past infection. This is reactivation. So essentially the early antigen, nuclear antigen, and viral capsule antigen really all need to be positive. And again, look at titers and just know that, there can be some cross reactivity, but I see these tests all the time, or I'll see even Quest Diagnostics, right? They don't have this full panel. Neither does LabCorp. They usually will do these, but you have to make sure then to add on a nuclear antigen or an early antigen. And you do really need all these to know if it's really reactivation. Sometimes it comes back equivocal, and I just treat them presumably anyway, presumptively, and get them better. A small percentage of the time I get people who still match the clinical picture, but maybe these are negative, and that's okay, because what if there's another virus causing these things, or a bacteria or something latent that I'm just not testing for? So in the world of conventional medicine, what are they doing, right? They don't have much to offer. And, I'm not knocking my conventional medical colleagues. I trained with them. I did my residency in emergency departments and other hospitals. They're great. But in this world, they're just not very good at it, because it's not something they know how to treat. It's something that we know how to treat, and we do it quite well. So if you look at all these systemic reviews, and here are the papers, only 2 treatments have shown to be effective, in systematic reviews. And that would be cognitive behavioral therapy and graded exercise therapy. And what else do they do? You're depressed, antidepressant. What's the side effect of antidepressants? Usually fatigue, low libido, sleep disturbances, worsening anxiety. I'm not against antidepressants. It's just that the person doesn't need one. Why give it to them? Sleep hygiene, that makes sense. Support groups, I also encourage, but that depends on the individual. Some people like talk therapy and want to be with people who have experienced what they've experienced. Some people are the lone person out, and that's nice because it also helps you determine their homeopathic remedy. Like a nature muriaticum is not going to want to go to a support group. A phosphorus, but by the time they have CFS, they're probably going to be more like phosphoric acid. They will probably want the support group, right? They want to talk to people. And then even conventionally, they're saying iron therapy in non-anemic patients with low serum ferritin. I like to see patients ferritin around 75, depending if they have neurological disease or not, but right around there, and just repleting them. So let's look at some naturopathic strategies, right? Which is, we'll do the second half of the talk, right? The meat and potatoes of why you are listening to me, ramble. So 2/3 of patients here with SEID, CFS, they report that they were dissatisfied with the quality of their medical care, and they felt their clinicians lacked communication skills and education regarding their diagnosis. So ergo, just support, right? That's just letting them know that this isn't in their head and you can help them. That's already starting them to feel better. And I can tell you that. And it's also self-selected, right? I get a lot of people who are either referred to me from a family friend or someone who I helped, whether they're in a support group or it's another doctor. So they kind of know what they're getting into. It's not just usually Joe Schmo off the street that's like, hey, I Googled you, or Googled the naturopath and you came up and I'm gonna see if you can help me. So they kind of know, and they heard me talk or read a paper I wrote on CFS. But for most of you out there, it shouldn't be any different. Is it just listening? And we're all usually very good at listening, right? We don't have 7-minute appointments unless it's an acute. And even then it's probably 15-minute appointment. So you got to try to find the accurate underlying abnormalities and address them. counseling and graded exercise. And these are my naturopathic strategies. Um, and sleep hygiene, if poor sleep present, and I would say it's about half the time. I get these people are like, well, they got cortisol dysregulation. Like, well, I get up around 10 and then or 8 and I'm good to go. And then at like 1, I crash. And then about 5 or 6 o'clock, I start waking up and that's my highest energy of the day. So I work until 1 a.m. Well, we got to switch that. And we know, and there's lots of ways to do that. Of course, diet, which is always the hardest thing to do with people. So you may want to build them up and make them feel better before you start, making all these crazy dietary interventions, because those are the people that just never come back, right? They don't come back for your second visit or third visit because they're overwhelmed. It's cumbersome. I mean, these people can't even get out of bed and you're asking them to do the allergy elimination diet or an anti-inflammatory diet. You got to build them up, make them feel better, also get them to trust you and you know what you're doing, and kind of plant little seeds about diet and then work it in there over time. And also, they don't want to disappoint you. You're the doctor and they look up to us, so they don't want to come back and be like, I didn't do it. So they'd rather just not even show up to the appointment. Of course, constitutional homeopathy, which we won't go into. Everybody, I wouldn't say everybody, a lot of people know I love constitutional homeopathy. Everybody gets a remedy with me. And this will be, for me, no matter what condition is besides acutes, right? Like pneumonia. I'm not very good at acute homeopathy, but for chronic disease, this is my number one weapon, and I get more results with constitutional homeopathy with anything else, and just makes all your other jobs easier instead of giving them 5 million supplements. Mitochondrial support, which again is not even needed that much. When we go through this, I'll show you why. And then using things like gemotherapy and oligotherapy. So for those of you who do not know what a gemotherapy is, a gemotherapy is literally herbs on steroids. So what they do is, and there are a number of companies that carry gemotherapies throughout the world. It's a way of where you take the botanical, and it's always going to be like the bark or the young shoot or the bud of the plant, and it's in its highest growing portion. So not only biochemically is the plant super strong, right? Because it's putting all of its RNA and DNA and all these other energy into growing the bud or growing the young shoot. Um, it's also energetically at its highest phase. And it's very sustainable because chemotherapies are diluted to a 1 to 10. They're not potentized, they're not succussed, but they're diluted to a 1 to 10, or like Viscum album is a 1 to 100. So you don't need much to make a lot of herb. And these things are super powerful and they work very, very well. Especially in this world, and I'll show you what I'm doing. And oligotherapy is essentially a mineral that is ionized, right? So it's not ionized by voodoo. Like for example, ionized calcium. Most minerals need to be in their ionized form to be active in the body, and that ionization comes from hydrochloric acid. Oligotherapy are physiological doses of minerals, not pharmacological doses, right? You give someone 50 milligrams of zinc, that's a pharmacological dose of zinc. Oligotherapies are minerals in physiological forms that are already ionized, so they're already kind of supercharged. So what I'm doing when these people come in, I'm doing complete history. Well, used to do a physical exam, but I still do some like on the camera. I might have, because everything is through the program called VC that I use, and I might have them do some stuff. But you got to look for themes and trends. Do they have fibromyalgia? Consider the Institute of Medicine diagnostic criteria. I tend to use more the CDC because for me, it's just simpler to remember. Constitutional homeopathy, which they're always going to get 99% of the time, they get it at the end of the first visit. Appropriate blood tests, which usually are a lot, and then have them come back in 3 weeks. And then, so what happens is I'm doing history, I'm doing physical exam, I'm going to talk to them, and people will say, well, how do you give them a constitutional remedy? For me, in my style, is I don't need these 2-hour appointments. It's not a separate appointment. By the time I've talked to someone, in most of my first office visits are between 60 and 75 minutes, depending on the person. And I charge by the hour, so I block out appropriate time for everybody. By the time I'm done talking to them, I've got a pretty good idea of between 3 and 5 remedies that they're going to need. Then I will switch into just like 5 minutes of constitutional intake because I've already got most of the information. I just need to narrow it down. So some open-ended questions, some closed questions, and then I end up knowing what I think their remedy is. And and plus people want to know that you did something. They just spent an hour with you. They want you to do something. So I take all their supplements. I tell them to just finish them all, unless they're garbage brands. I'm like, don't even, you just give them to someone else or throw them away. And then I give them a therapeutic dose of those. So I make them finish up their supplements. I do the constitutional remedy and I mail it to them. I give them a lab requisition, or stool or urine or whatever I'm going to do, or all of them. And then I have them go get all of the blood tests and all the testing done. I reviewed some of their outside records if they have them, if they're relevant. For me, I don't want anything that's more than 6 months old. It's just not relevant to me for most anything, unless it's maybe like an MRI they had 8 months prior. I do want those reports from the radiologist's interpretation. And then I look and see what happens. So they come back in 3 weeks and I basically am addressing all the abnormals. And if they're positive for Epstein-Barr virus, cytomegalovirus, and or HHV6, or if these are negative, but they present symptomatically, this is what I'm giving them. I'm doing a combination of 3 chemotherapies, which is Acer campestri, Juniperus communis, and Tamarix gallica, and an oligo element, which is copper, gold, silver, and I prefer these in liquids. And the dose depends on the company that you're getting it through. So I use, and I have no affiliation with this company whatsoever, I use Unda. And because I like Unda and the stuff really works, and I've used other companies and I would say they work, but then I had issues with back orders and them sending me the wrong things, and it was just too many problems. And I've never had problems with Unda for 15 years. So these are 4-ounce bottles. I tell them to get a 4-ounce tincture bottle. They can order anything on Natural Partners or Emerson or Dr. Supplement Store, or whatever you want to do, or you stock them in your office. And then they pour 1/3 of each of these herbs in that bottle. And then they take a teaspoon of that mixture twice a day with 1 dropper full of the copper, gold, silver. I don't use Unda because I don't like the way their copper, gold, silver, which is a tablet. I don't think it works that well. Most people don't like the taste. It's very metallic-y. So I use a different company. Again, no affiliation. I use professional formulas, and it's, I don't know, $14 or whatever. And then that bottle, and this takes about 6 weeks for them to finish these. So what I have them do is just the gemos, and I also assess what the homeopathic did and did not do. They do the chemotherapies, they do the copper, gold, silver, and then I say, and it takes about 6 weeks. So some people, you have to go less on the gemo and the oligo in the beginning, like it's just too much for them. They get like a die-off reaction, they get worse fatigue, they get headaches, they get brain fog. I just tell them, start these. If you feel, if you don't feel well in any way after a few days, email me, and then I tweak it from there. Take half a teaspoon twice a day. If they don't like the taste of it, they can put it in water, or like an ounce of water, half ounce of water, just shoot it. And I have them do that when they get up, and I have them do it when they go to bed. And same with the copper, gold, silver, 1 dropper full of the copper, gold, silver. They could take it with the chemotherapy. They should. The oligo element essentially supercharges the already herbs on steroids. And then I have them come back, in 6 weeks, and I basically kind of assess them. How are you doing? And I would say 98% of the time, if this is the cause of their chronic fatigue, they feel at least 90% better. It's that quick. And it will blow your mind the first couple times you do it, and it will blow their mind. I've taught many, many clinicians this, and they've all reported back to me over the years that, holy crap, this works. So it's not just me, so the only person seeing this. I've seen a lot of doctors. I've had doctors in my practice do this with their patients, and they're just like, oh my God, this is crazy. And it is crazy, but it only works if their causation is Epstein-Barr or some kind of reactivated virus. So then usually they're like, I'm way better. And now they're so much better, they will do anything you say. And now you can start doing diet and things. They finished up all their old supplements. And I've noticed kind of this great consolidator supplements. I'm like, all right, I'm going to put them on a nice potent multivitamin mineral. I don't like these crazy 6-a-day ones. And again, it's not me. Look at the data. Plus, look at those papers earlier where they had this hypometabolic syndrome from the metabolomics. You got to start getting some stuff into them, some goodies. I like the 1-a-day whole food multivitamins. I usually give people 2 a day. If they need iron, I give them the ones with iron. You know, pick your company, but make sure that it's a good. I like the whole food ones. I think they work better, and I do see people tolerate them better than the synthetics. So, and then I also start cleaning up their gut just based upon the data, and most of them will usually report some kind of gut dysfunction. So fermented foods, I give them a handout that has all these lists of fermented foods. I have a stewed apples recipe that was shown in mice anyway, mostly about how it's anti-inflammatory to the gut. It's slow, but it's food. They make these huge things of stewed apples. They put cinnamon in it. They eat it a couple tablespoons a day. They love it. They can keep it in the fridge. Adding in prebiotics, you know, probiotics, Saccharomyces boulardii, right, a non-colonizing beneficial yeast that regulates secretory IgA. It's you know, competes for yeast pathogens. I mean, it's wonderful, and it's non-colonizing. So once they stop it, it has a washout period, just like probiotics, right? Probiotics only work as long as you take them. Some infer benefits up to a certain amount of time after you've stopped taking them, but it does have a washout. Prebiotics, on the hand, right, indigestible fibers, those are actually what feed your healthy flora to grow. And a lot of people say, well, my patients don't tolerate FOS. And the reason most people don't tolerate FOS is because it comes usually from inulin. And you got to take like 10 grams a day to have any effect, and they get all this gas and bloating. If you use it from hickory or carob, chicory or carob, they tend to tolerate it better. You can also give them a lot lower doses. I prefer things like XOS, which is oxalo oligosaccharides. It's usually from non-GMO corn cob, and you actually only need to give them about 1/5 the amount, about 2 grams a day, to get therapeutic efficacy to induction of bifido. But just start cleaning up their gut. So right, I saw them, they came back in 3 weeks. Then I gave them Gemos, they came back in 6 weeks. And then I'm telling them to kind of come back and again in another 6 weeks. And so now they've been seeing me for a total of, you know, what, 3 months, 4 months. If they come back after they finish the Gemos and the illegal elements, so it's like their third visit, and they're like their waxing and waning flu-like symptoms have all resolved. The virus has been killed enough, so now the goal is to get their immune system strong enough to keep the viral load down, to keep them better without it reactivating, as well as just making their energy better. So I give them ribes nigrum gemotherapy, and this, you know, dosing can be anywhere between, you know, 10 drops to a teaspoon, once or twice a day. It is a very yang tonifying, very stimulating herb. So just tell people if it messes with your sleep, makes you feel jittery or agitated, just take less. Most people with chronic fatigue, they need the extra oomph. And I usually just have them take it when they get up and at noon. And then for those that aren't better, but they respond to the therapy, like I have patients come in, you're like, you know, I'm 70% better. But yeah, no, I still get some sore throat that comes and goes. I still feel like I'm getting a fever. You know, I will repeat the Gemos for another 6 weeks. And you rarely have to do it. Sometimes maybe a couple years go by and your patients start having the reactivated, but they know what it's like when their stuff's reactivating. They just go right back on the Gemos for another 6 weeks and they're fine. So what about that 2% that's not responding to the Gemos, but there's still some kind of viral illness? That means just those Gemos aren't working with that particular infection. So I will give them, or maybe they didn't respond enough, even after 2 cycles of gemotherapy, I will actually give them pharmaceutical antivirals. And your scope may not allow this, so you'll just try to maybe get someone else to prescribe it for you. The one I've used the most would be valacyclovir. Valganciclovir, I just put in there because it does have papers using it in chronic fatigue. I've prescribed it a couple times. You know, sometimes people's insurance kind of don't like it, so I just kind of go by my old standby of valcyclovir, like 1,000 milligrams 3 times a day. And I usually do give it to people for 2 weeks, and then I say check back in with me. Also, you need that look at their kidney function, because if they do have some kind of kidney disease, you have to adjust these antivirals. Humic acid, right? Humic acid is a substance that's found in all organic material, but it's really high in like volcanic areas like Iceland. And humic acid, I would say, works, in my experience, it only works like okay for Epstein-Barr virus and cytomegalovirus, but I've seen it work like gangbusters in the herpes simplex family. Say even someone has herpes simplex 1 or 2 and they get the prodrome, and you have them take 1,000 milligrams 3 times a day of this, or 1,500 milligrams twice a day, it shuts down. They never get an outbreak. If they come to you and they've already broken out, then there's other things I'll do. And the mechanism of action is that what this thing does for most viruses, at least what we've seen in vitro and some small human studies, is that it binds to the virus and it doesn't allow it to get inside the cell, hijack our machinery, and replicate itself. So again, what about those without infectious correlations? Start looking into heavy metals, right? And thinking, because, and this is what triggers me to start looking into people, excuse me, with heavy metals and some of these other things, is that if you practice medicine long enough, no matter what the condition is, unless it's something you haven't seen before, you should be able, if you're comfortable and confident with your diagnosis, you should be able to put something into the system, i.e. give them something with a known outcome. You should know how that person should respond. Yes, there are outliers. You got the super sensitive person that might, you know, react weirdly, or they need a lower dose, but right, they're on the other side of the bell curve. They're like down here, not the people under the area of the curve that respond normally, which we see a lot, right? We see a lot of the people who don't respond normally, and that's why they see us. But either if they don't respond normally, either you have to rethink your differential diagnosis, or you got to look elsewhere. Something is interfering with what should be going on. And like this gentleman who could only walk, 2 blocks without basically being in a wheelchair and having to come home for a week. He had literally had seen a lot of very good doctors, people I know, some people that are just, they charge a lot of money and they're famous and they're probably not all that good, because he had it for almost 30 years. And the reason the IVs didn't work and the saunas didn't work, and the mitochondrial and all these things he'd been doing over the years didn't work, is because the guy was full of mycotoxins. You had to get rid of those in order for everything else to work. And he actually came back high on his mycoplasma pneumoniae. So I gave him a dose of azithromycin with a biofilm product, and then gave him itraconazole, which is a great antifungal. You give them 100 milligrams twice a day for 30 days, and then you reassess. Some people don't. Some people need it for 6 months. Some people need it for 30 months. 30 days. Some people 3 months. But most people, they seem to respond pretty quickly. Do be aware that there was some die-off things, so you got to kind of prep them, right? So give them a good multi, get a homeopathic on before you start giving them things like itraconazole. Give them some liver support, give them some NAC, some glutathione, then give them the itraconazole, which is better than diflucan. It's less harmful on the liver, and it also, that's what Dr. Andrew Campbell taught me years ago in one of his seminars, and it does work quite well. And he responded beautifully to the azithromycin, the biofilm, and then the itraconazole. And now we're just working on mitochondrial support to repair the mitochondria that have been not doing well for so long. Of course, investigate small intestinal bacterial overgrowth, right? I have so many people with just bizarre symptoms, and then this is it, and you get rid of this and they're like back to normal. And here's a study showing SIBO and chronic fatigue syndrome. Of course, treat the adrenals, make sure they're eating regularly, high protein snacks, good quality food, stabilize the adrenal glands with our lovely adaptogens, and do, of course, look into food sensitivities and tolerances and allergies. And right, there is a difference between a food allergy, a food intolerance, and a food sensitivity. A true food allergy is someone who eats the shrimp and they have a type 1 IgE mediated reaction where they get urticaria or scratchy throat or hives, or blue lips, all the way to anaphylaxis. A food intolerance is not mediated by the immune system. It's an enzyme insufficiency or deficiency, and you do not get symptoms outside the gastrointestinal tract. Right? Lactose intolerance being the most common in the industrialized world, that you don't have enough of the enzyme lactase to break down lactose. And then sensitivities is more of the world that we live in, that they may or may not be mediated by the immune system. So what is theorized in research papers is that the possible postulated reason why people get extra gastrointestinal manifestations from a food sensitivity is that those are what's mediated by the immune system. If it's not mediated by the immune system, it kind of stays here. And the only way to really know truly would be the allergy elimination diet, and then IgG food testing, which has only been proven in a couple conditions, which I use a lot of times in kids, right? It's too hard to do the allergy elimination diet. But get rid of those. You're like, yep, doc, I've done all that, no luck, which is extremely uncommon in my experience when, you've done everything else, looked everywhere, but you got to dig and treat based upon the symptom picture, right? So they're fatigued, they've done everything, you've even done everything. You're like, well, I think maybe now, and we got you from your energy level from a 4 to a 6, and some days you get a 7. Well, let's start adding in mitochondrial support. And again, I don't have to do this very often, handful of times after the other stuff. And even before this, people were already at least somewhat better. Um, the usual suspects, right? Magnesium, and these are all oral. These are not IV doses. Coenzyme Q10. You got to see the doses are pretty high, right? Because you got to literally by mass effect push the biochemical reactions in a way that you need to go to make those mitochondrial kickstart. And what I talked about earlier is that, one of the hypotheses of mitochondrial dysfunction, you can put in all the precursors you want. If the mitochondria has a leaky membrane and mitophagy is not working appropriately, right? You're not breaking down the mitochondria at a normal rate. And so the defunct ones are kind of hanging around, and those are the ones that are dividing and replicating their own dysfunction, that you're not going to get the mileage you're going to get in a person who has normal mitochondrial membrane. So the goal then is to repair that membrane through a mechanism called lipid replacement therapy. And there's lots of papers on this. And all it really is giving someone, whether it's IV or oral or both, a massive amount of phospholipids and glycophospholipids, right? You're looking, and I've been doing this a long time, that I haven't really seen much movement with people until I start getting to like 6 grams a day. And there's products out there from certain companies. I personally like to just do lecithin, sunflower lecithin in liquid, or I usually ask the person, will you do a liquid, will you do soft gel, whatever, and I have them take maybe a gram, 3, 4, 5. I might have them give them like 3 grams twice a day, usually morning and night. And you got to repair that membrane. And then all of a sudden you start adding in these precursors and they will work. And I can promise you that just based upon clinical observation. And then using something like NADH, right, which is, really important for energy production. Most supplements, NADA is not stable. It oxidizes quickly and it's not very bioavailable. So there are a couple of 2 brands out there, not brands, companies, not like supplement companies, but actually vendors that make the material that have been shown to be stable and have been shown to be efficacious in humans. This is different for IVs, but if you're going to give someone NADH orally, you're either going to have to find a product that has it called Panmol, P as in Paul, AN as in Nancy, M as in Mary, OL. Lots of supplements carry it. And then the other one is Niagen, which is from a manufacturer called Chromadex. Again, you can go on Natural Partners Image and just type those in and see which brands carry that. All the other NADH that is orally, that is not from those 2. It's a waste of money, honestly, because you're just not absorbing, the patient is not absorbing it, and study after study show that. But if you use those 2, they do work. I don't have any affiliation with any of those people. I'm just reporting to what the data shows. And you could actually get these in lozenges, and I'll have people just dissolve the lozenge in their tongue, like 10 milligrams twice a day. Be cautious that when you start giving people this, they'll get perked up pretty fast and might get all hyper. So then you got to taper them down. And then, of course, using, D-ribose, which I do like a lot, as a sugar. And these dosages are really high because they're also individually, right? They're not, if you're going to find a product or you're going to use a multitude of products, you don't necessarily need doses this high, right? Because you're using really by synergism, right? By the entourage effect, if you will, how it's going to work. So you can use L-carnitine, acetyl L-carnitine, propionyl L-carnitine, and these are all different in the body. I like L-carnitine more for ATP Acetyl-L-carnitine, I think more affinity for the neural system, and it does cross the blood-brain barrier, but it's much more expensive. Propionyl-L-carnitine is much for cardiac function. So sometimes I'll use a product of these two with some ALA, and they seem to work quite well. Notice that when you get into these 300, 600, 1200 milligrams a day orally, even IV, that those are that's hypoglycemic. So people need to eat within 20 or 30 minutes of taking them. And lipoic acid, when taken with meal, inhibits absorption. So I usually have people take about 30 minutes before the meal if they can remember. Other support, your EFAs, your 369s, super crucial, right? Because what's important to these is that they're anti-inflammatory, and they're really necessary for the fluidity of the cell, for the cell to be able to communicate, for metabolites to come in and out of the cell, nutrients to come in and out of the cell. So if someone has a bunch of unhealthy saturated hydrogenated fats in their body and their blood, and they're like going to be like motor oil, then they're not going to be working as well. And again, here's kind of case controlled studies of chronic fatigue syndrome and the use of fatty acids. And they all essential fatty acids do different things. For people with chronic fatigue syndrome, I like to give them a 3-6-9 blend. So you got the EPA, the DHA, the DPA, omega-6 in the form of ganolinic acid, and then usually the omega-9 is like an oleic acid. And but you got to get a lot into people. Usually it's too many pills. So I'll give them a tablespoon a day, or slowly work them up to avoid the gastric distress. And I would say 10 to 20 grams if they have a lot of pain, particularly if they've got fibromyalgia and chronic fatigue, because you'll see this a lot in medicine, is that people say, oh, naturopathic medicine doesn't work, natural medicines don't work. And they sure they do. The reason they don't work typically is that it's either underdosed for that person's disease. It's not a preventative dose. It's not like you're taking 500 milligrams a day to prevent heart disease. Someone has a traumatic brain injury, you got to give them 20 grams a day, especially if it's a severe one. Or it's just really poor quality supplement. How many times have we all seen someone come in chronic pain and they're like, oh, I tried turmeric for that. You're like, well, did you? How much did you take? What brand is it? How long did you take it? How many times a day were you taking it? And usually they'll come back to you and say, oh, it's just something I got on Amazon, or I bought it at Whole Foods, and I was taking it a couple times a week. Well, that's why it didn't work. You just didn't get enough in you. So let's look at our wonderful world of our botanicals, right? And especially because there's a lot of two out of three people, 2/3 of patients have a neuropsychiatric issue. So it's even more important in my mind to use adaptogens because they help with fatigue and stress and mood and pain. A lot of them are showing, at least in ashwagandha, they're showing pain studies now, efficacy in pain studies. And the reason the doses are super high is it really has to do, one, yes, the studies were done on just one intervention, not numerous, holistic approach like we do it, but also depends whether it's the crude herb or it's a standardized extract. So like in Ayurvedic medicine, a lot of times, and in Chinese medicine, right, they're using the whole herb, and that's why you're taking 15 grams a day. It's not a standardized, highly concentrated extract. And I'm just putting in ones that are also my favorites, and two that also has good research evidence. This is an evidence-based, clinical-based talk. So, the Withania somnifera, Panax ginseng, and the ginsengs, right, and all adaptogens, they run on a spectrum. So from, again, for Chinese medicine, from yin tonifying to yang tonifying. So if I have that patient who's like wired tired, especially after you kind of start cleaning them up and they're coming back to the way they used to be, high functioning, I don't really want to give them Panax ginseng because it's just going to amp them up even more, even at low dose. I might think of using Panax quinquefolius as long as it's ethically wild harvest or cultivated, since it is over harvested, and given the more yin tonifying, or maybe Eleutherococcus, right, Siberian ginseng, which is more in the middle. But if I have that completely depleted person who's cold all the time, or even our seniors, our elderly, I'm going to give them Panax ginseng. I need to get more bang for the buck. And then, other favorites, glycyrrhizid glabra can't be overstated because it's anti-inflammatory, it's antiviral, it's immune modulating, and you know, it increases the half-life of cortisol. And it also, the saponins in tinctures, it helps with absorption of other botanicals in the body. So if you're going to use it well, it doesn't matter whether it's a supplement or tincture, is that, you got to look at the glycyrrhizic acid content. Um, this should actually say 400 milligrams because they can get hypertension, right? But if they have POTS or they have orthostatic hypotension, this is a fantastic herb to use, and I'll give it to them a lot of times as a solid extract and tell them to take a teaspoon twice a day and add some salt to their food because they have low blood pressure, right? They're going from sitting to standing up, and all of a sudden their heart rate goes up and then their blood pressure goes way up, but then sitting, they're super low. I like to give this to them. People who don't need that, you just got to keep it within, and some people even at 100 milligrams of glycyrrhizic acid, they're sensitive. They're just sensitive to glycyrrhizic acid and they'll get hypertension. I've unfortunately had patients call me very irritated that, they went into their doctor for their annual and now they're hypertensive, or they even themselves, they felt like they had a headache and they went to get their blood pressure taken and it was, sky high. Typically, you can help offset that because, right, this is an aldosterone antagonist, is that you can just give them potassium rich foods and potassium supplement, and then you get more glycyrrhizid into them. And I rarely give them a supplement. I just tell them to eat more potassium rich foods. It's a way to have them, I have a handout with all these foods that have high in potassium and get more healthy foods into them. We already talked about, right, being Zygroup Gemo for botanical support. And I don't leave this on people forever. I just do this if they really need it and they gotta, they have to get the oomph quickly and maybe leave it on for a few months. They don't need it anymore. Astragalus membranaceus, one of our favorite herbs in Western medicine, Western herbology, as well as TCM, CCM, is that it's like, what does an astragalus do, right? I mean, it's anti-cancer, lengthens your telomeres, immune modulating, antiviral, it's an adaptogen. I love astragalus. Sometimes you can even get the bulk herb in like these little sticks that are kind of cut in like little chips, and people will chew on them, and as they chew on them, they actually, your saliva mixes with those polysaccharides and it turns sweet tasting after a little bit. Not everybody wants to chew on them, so tincture, capsule, tea, whatever. And then kind of some other strategies to consider, I just throw these in there in case you get those tough cases, or it's like, okay, chronic fatigue is gone, but their fibromyalgia is still there, or their chronic pain, or you peeled away one layer or two layers of the onion, and now there's just more stuff there for you to deal with. So certainly considering hormone replacement, biodynamic hormone replacement therapies, particularly if I don't like to give hormones unless I need to, and then taper people down once they come into optimal levels. So if their testosterone is low, or their pregnenolone or DHEA, or whatever, and how to do that, that's a totally separate webinar of dosing and form of hormones, but just pick your poison, what you like. IV-IM therapies, when I had a practice, I used to get this thing that was a compounded L-carnitine, B complex, and it had a few other ingredients I'm spacing out at the moment. And I would just drop 1 or 2 cc's and inject people, into the glute, and just kind of get their tissue saturated real quick, and have them come in once a week for a month, and maybe like twice a week for a month, and just really get them juiced up, even if it was short term, just because trying to get them through their day before all my other treatments kicked in. I don't do a whole lot of IV therapies. I mean, I used to when we had a physical practice, we had a large IV clinic. I still refer out to them sometimes, but really it's like when nothing else is working, and I haven't seen that in 10 years really anymore. I used to see a lot at Bastyr. People would get treated forever with chronic fatigue syndrome or reactive Epstein-Barr for IVs, and they would spend thousands of dollars, and they wouldn't get much better. And that's when I started looking at this. I'm like, this doesn't make sense. There has to be other treatments for CFS. Physiotherapy, hydrotherapy, I mean, just look at this. I mean, it just looks relaxing, right? And therapeutic. Wish I could go there every day. Acupuncture, particularly for pain control, stress, sleep dysfunction, massage, craniosacral therapy. I've just known these are out there sometimes, and sometimes you know, again, it's not just how many patients do we have that just come in with one problem. It, not very often. So you may have to bring out a multitude approach once you get them better. If they come in and these people can barely get out of bed in the morning, last thing you want to do is be like, I'm going to give you a treatment plan with 12 things on it. You'll never see them again. And so I think we're coming to the end here. So other strategies, again, this is mostly for pain or people that have autoimmune disease. Um, I don't know how much evidence there really is, you know, with chronic fatigue syndrome. There certainly is with chronic pain, like fibromyalgia, and the use of low dose naltrexone. And here's its mechanism: increases endorphins, and that's why you have people take it at night. I usually start people on. I usually have it compounded as a liquid suspension, 2 milligrams per ml, and that way they can titrate. I start them at a mill, you know, versus giving them capsules. You can't titrate a capsule. They're gonna break them open and like cut up a bunch of powder. It's a pain. So I like to be able to be like, oh, you didn't tolerate that. Let's go up. You know, let's go down in a dose, go up in a dose. And then common side effect, right, would be though the, you know, nightmares, bizarre dreams. Usually goes away within about a week. If they've been taking this for 3 or 4 weeks and they still have sleep interruption, give it to them in the morning. Still seems to work. And then you have 1% of the time people just do not tolerate naltrexone. And obviously the caveat is if they're on some kind of opiate or narcotic, they can't take naltrexone. Like if they're on tramadol, you know, or oxycodone or something, they can't have it because then their pain meds won't work. I put this in here. I don't use it a whole lot, but it has some good data. And the reason I don't use it is that it's expensive, even at low doses. But just to know that you're like, well, I got a patient that isn't really responding, and you know, maybe I'll try some organic germanium and make sure it's organic germanium, because inorganic germanium can cause renal failure. So you get the organic, which is totally different. And people say, well, how do you know the difference? It's not like the label's going to say that. You just got to make sure it's from a good brand. Jaro carries one. Allergy Research Group carries one. I'm not affiliated with Jaro. I am affiliated with Allergy Research Group. I do not receive royalties on any sales of any product. Just that's my disclaimer. Because I do work with them. And Douglas Labs, who I'm not affiliated with, also carry organic germanium. If your patient's buying anything besides those three, just tell them to stop taking it, because I don't know what's in those other ones. Those three, I know they're verified, those companies. And then again, we talked earlier about kind of getting the person's immune system. Once you get everything under control, is basically trying to keep their immune system in check so the virus doesn't replicate again, because it's still there. It's just now the titers are low enough and you got to stimulate their immune system. Colostrum can help a lot, right? It's anti-inflammatory. It has immunoglobulins. And here's some good studies showing its efficacy for not necessarily chronic fatigue, but with immune function. So what are kind of the take-home messages, right? It was a lot of information, but you have the slides. You can always pause my pontification and, you know, go back to it. That CFS, SEID, it's a multi-system condition. It's multifactorial. But if for an open heart and scientific inquiry you're utilized, you can drastically improve your patient outcomes. I can't implore you enough that diagnose first, right? How many times does that patient come in the office and it's just shotgun, all green allopathy? Here's this supplement for that. Here's this for that, this for that. And people don't get that well. And sure, you can probably make a lot of money because you're selling a lot of supplements, but we want to get people better, and we want them on the least amount of stuff for the least amount of time as possible. Consider naturopathic therapeutic order. I mean, these patients, it can be very overwhelming, particularly when someone is first in practice, right? That they come in and they're all over the place and they got a million things going on. And then at the end, it's like, oh my gosh, what do I even do with this person? For me, you know, it's a little bit more autonomic now, but in the beginning, the first few years of practice and out of residency, you know, it's like, okay, let's just start with some simple stuff, some Epsom salt baths, some castor oil packs. Just think about your therapeutic order. You don't have to go right to the medications. Sometimes you do, But once you get enough experience, you'll know when to actually, okay, this is what we need now because this other stuff, I just need to buy myself time. Like if I have a patient who is in chronic pain, they can't sleep because of muscle spasms, I'm going to prescribe cyclobenzaprine, you know, maybe in a small amount just to get them sleeping at night, so then I can start doing everything else. Uh, whenever you're drawing up, try not to overwhelm, particularly these individuals because they're exhausted. They can barely get out of bed sometimes, or they can barely get through their day. They're always wiped out at 4 o'clock in the afternoon. Last thing you want to do is give them a treatment plan with 27 things on there. Just three, you know, three basic things. And then, of course, the principle of KISS, right? Either keep it super simple or it's keep it simple, stupid, whichever you'd like to see. And I want to thank you for your time, your listening. I hope you enjoyed this and you found it to be useful. If you ever have any questions, you can always email me at dr.born@bornintegrativemedicine.com. Thank you.